This is Hold My Stethoscope.
No, I like your setup. Hey,
Thank you.
we are back, guys. Welcome. I was just saying, I really am enjoying Felicia's new little studio area there. It just feels so comfy and cozy. It's
It
great.
is and very I would love for you to see the whole thing because this is just one side of it.
Yeah,
It
well,
is
I'm gonna
ve
maybe next week I'll come over and we could record together. I
You
don't
know
know. We'll
what?
have to
That
see.
would be absolutely amazing. Yes,
Yeah,
and we both can sit at the table and just record and relax and
me
record
too.
R&R.
Yeah, we need to for sure because
Yes.
it
Hi,
it's
everybody.
hey,
We're
yes,
here for another
welcome.
episode.
I know. I was like, we hadn't recorded in a while, and now it's like, oh, we're kind of trying to get back on that routine again, and it's
Yes,
nice.
it
So,
is nice.
you'll be seeing that new episode soon, obviously, and then this is the follow up to it because we said last week for the last episode that we were going to talk about kind of what's changed in the ER. So, when I first started in the ER, it's been my gosh. Okay. Probably 15-ish years at this point since I've been in the ER is definitely a completely different world than it looks like today. It's so different. It's changed a lot. And I mean healthcare and medicine is constantly changing, but it's a very different world than when I entered 15-ish years ago. What about for you?
It is majorly different. Of course, mine has been a lot longer, but the patients have changed. Healthcare has definitely changed. The nurses have changed. But is it all for the worse or is it just different? That's really the question.
Yeah. So today we're going to kind of talk about what we've kind of seen over the years, what's gotten harder, what's maybe gotten better, and just what keeps us coming back. And we've talked about that in previous episodes about how the ER just kind of has a hold on people. But yeah, let's talk about it. So we are
Okay.
talking specifically about the ER and our experiences because that's what we know. So
Right.
where you go back to your journey for a second, because I know you were like paramedic and LPN and all of that stuff. So, how did you get into the ER in the first place?
That is such a great question. So initially, I worked at one of the sisters hospitals of the company that we work for as a unit secretary while I was getting my LPN. That was what was crazy. I got my LPN and I did that within a year because I don't know if you guys know, I did not have a desire to be a nurse. My whole desire was to be an FBI agent. That was my plan. That was not God's plan. Okay. So that is why God is in control because I thought I was going to be that FBI agent, but God had other plans for me. And there's always a reason why. And I thank God for it today. So I decided when I moved to Florida that getting into that medical field just seemed the way to go. There were people that were actually moving down to Florida. I'm not from Florida, but they were moving. Lots of people were moving here. Elderly people were here, and it just seemed like there was a need in medicine, and which is what led me into it in the first place. I decided to go that LPN route, even though my plan was to do the RN. But at that time, everybody would say, do this route first because this is going to be a lot faster. And you know what? They were right. And I'm glad I did it because it gave me such an amazing foundation. I knew as an LPN that I did not have the desire to be an inpatient nurse. I don't know what it was. My hat goes off to everybody that does inpatient nursing. God bless you. I needed something that had me driven, but I didn't know what that was. As an LPN, I didn't know. And back when I was in school, they let you take little field trips. You might go visit in the OR, you might go visit in the ER. This is when they would let you go in the ER and everywhere. And I'll never forget, like NICU, whatever. I'll never forget going into the ER and then going back to post conference to my clinical instructor and saying, "Well, I'm gonna be an ER nurse." And I remember her looking at me and was like, "Oh, really?" I'm like, that is me all day. I don't want to get to know anybody. I want to keep it moving. So that is actually what led me into the ER. And I was in the ER as an LPN first and went on and got my RN. But I knew before even getting a license, I'm gonna be in the ER. That is more of my drive. I want to see the blood. I want to see what's going on. I like all of this fast pace movement. Get them fixed, move them out. Next patient, not coming back, seeing the same patient again, saying, "Oh, hi, I saw you yesterday." Not that. Like there are people that like to come back, but it's different. It's not the same as caring for someone on a constant basis, and I just knew that the emergency room was the drive for me. It wasn't any, like, earlier passion, some may say. It was simply just getting that opportunity in school and saying, "I think I found where I belong." That's what it came down to. How about you?
So I knew I was
Okay.
really early age. I don't know what it was, but I just really loved it. And I always thought I was going to do like doctor, PA, and all of that stuff. And then in high school, I got an opportunity to do what they call this youth apprenticeship program.
Yes.
So for my senior and junior year of high school, I got to go and spend like a year in 4 different areas of the hospital. So I got to I was in radiology for half a year, pharmacy for half a year. I was on the OB unit doing nursing for half a year and then like rehab for half a year. And
Okay.
I just realized that nursing could open up a lot more doors than maybe some of the other fields I was looking at. So I went
Mhm.
to nursing school right out of high school, graduated with my RN, and I started on a med surge floor, kind of like, was
Okay.
the traditional route back in the day,
Right.
right?
Absolutely.
And did that for about two, maybe 3 years. I think it was like 3 years. And I actually really thought I wanted to go to ICU. Like I loved critical care and I thought I was meant for ICU. And so I applied to the ICU and I think I applied to both the ER and ICU kind of around the same time, and I did not get the ICU job, but I got the ER job, and I was like, "Okay, once again, this
God knows. Mhm.
God knew," because I am a very classic ER nurse, and I would have not I don't know, maybe in a different life, I would have done good in the ICU setting, but, like, you have to have I feel like most ER or ICU nurses have that certain personality, and I realize I do not. So, I think the ER was the best choice for me, but so I started, my ER career in the hospital, like, I literally did my apprenticeship with, and it was, like, the first hospital I worked at and all of that stuff. So, I started there. We were I don't know, 20 to 30 bed ER, maybe 40 beds. I honestly, it's been so long, I'm like, I can't really remember. But we were like a, community ER. We saw everything there. We had a level 2 trauma center kind of about 5 miles down the road. So I'm from a smaller area in upstate New York.
Uh-huh.
That's where I was born, raised, did all my stuff. There are about 3 hospitals within about a 10-mile radius of each other, but that's, like, essentially all the hospitals that are, like, within a good 50-mile radius. So it serves a large community, those 3 hospitals do, or at least they did back.
Hmm. But they were that close?
They were super close. Yeah, so, like, the
Wow.
level 1 level, trauma center in our area, and it was a level 2, and it was literally, like, 10 minutes away, and then the other hospital was, like, 10 minutes the other way, so, like, we're all very close, but then that's,
Okay.
like, it for a bigger radius. So, but I learned a lot there. I can't remember how long my, like, orientation was there, but it was there was definitely rough periods because you don't,
Yeah,
especially coming, and I love it. Like, I'm always one still to this day that's like, I love that I got a med surge experience. I love that I had that background because it really did give me the foundational
it does.
needed. But at the same time, it's a completely different way of thinking. And that took me a while to kind of unlearn that
Mhm, mhm,
surge way of thinking and
mhm.
transition into an ER way of thinking. And, being able to kind of learn a new set of people and learn new processes. So it definitely was a transition. And like I know the organization we have now, and a lot of organizations these days have like a internship program
Internship.
or some kind of more of a better formal transition into a specialty. Didn't have that, just kind of was like go and figure it out. And
Right.
I mean, I did, but it definitely took me. That's why I'm like, from experience, it was a good year before I could really like
Yes.
truly like get things. And it was I had a great preceptor, Erica. If you're ever listening to this, I still remember she was preceptors in the ER. And she was so patient and so kind. And it was great. She really gave me like the guidance that I needed to kind of thrive. And she was kind of like also did like relief charge. And so it was kind of funny because I've talked about this pediatric code that, my first pediatric code that I did.
Yes.
She was like the charge nurse that like evening, night, whatever it was. And I was working in a different kind of area, but she kind of like knew me. And I, at that point, knew that I had experience and all of that stuff. So she specifically grabbed me to come into the code to help run it. And I was just it was just it was definitely a great learning environment. It just was so different, but I fell in love with the ER because it was just like, that is what I want to do. But it's just a different, I don't, it's hard because when I went into nursing itself, and I know you were like this too, we were on paper charting. Like
Yes.
when I graduated nursing school, we were still on paper charting. So we transitioned within my first 2 years to electronic
Mhm.
charting, but it was still new and it was still a process that people were gathering. And I feel like that
Yes.
is one thing that's definitely changed is kind of the documentation has become a lot harder, stricter, whatever you want to say. It's just a lot different than doing. I mean, once again, I worked med surge. So we did one like soap note
So nope.
things changed for our patients during their 12-hour or 8-hour, we did 8-hour shifts back then. 8-hour shifts, that's another change. 8-hour shifts for these patients. So, like, I it's just different. Your charting requirements are so different than they used to be. I think that's one of the things there. Yeah, what was your experience like with
You know what? It's so
the
interesting because
accreditation?
I admire that, Brittany, because there was no internship. I didn't really even have a preceptor. I remember going into so I worked at in another organization prior to the one that organization I currently work in. I was working in the emergency room there. That's when I was the LPN. And I got very little training, but I did get some training. But because that hospital was a level one and there were residents, it made it difficult whether I've been an LPN or RN to really get the training that I need. However, I started to adapt. You adapt and you learn a lot by the mistakes that you make. I remember a paramedic teaching me IV skills. It wasn't your traditional preceptorship orientation shifts like we provide now or even some years ago. I didn't have that. And then because I
So,
wanted
were you
more,
just like they're like, "Just start," and then, like, you just figure it out as you go?
you start and they give you people, different people. But to me, when you're brand new, that's not always good because you're trying to find your way, but you don't really know what way you're trying to find because they're putting you with different people. But when you're so fresh and so green, You need somebody to be consistent. So I'm with a paramedic at one point doing this. I'm with an RN. Now I'm an LPN. Never was there an LPN to train me. So it was an RN that gave me some training. And then it's like, okay, you're on your own. That I did for 8 months before I transferred. That was a good thing about not being or not having an obligation to an organization where you owe time. I then went to the current organization that we worked for many years now. And that is where I really learned my nursing skill. However,
Did you go there as an LPN or did you go there after you
I went there as an
graduated RN?
LPN.
Okay.
I went there as an LPN, but then quickly, not long after, the decision was being made that they were trying to get, you know, do away
Phase
with
in.
the LPN, make them the discharge nurse. And I was like, I'm not being nobody's discharge nurse. I don't want to be the discharge nurse. And I went back to school. This is when I started working nights. So I started working nights while I went back to school. I had already had plenty of prereqs because I already had two bachelors. So I was able to pretty much jump into a LPN, transition to an RN program. So you eliminate a couple semesters already. And that's when I went on and got my RN. But my experience was we didn't still really do, they did give me someone to precept with when I moved on to our organization. But it was more like they would put you in the ER and the staff would decide if you'd work out or not, pretty much. Like it was bizarre. It was, looking back on it because I then became that person as well. Like people would come in and we'd be like, oh no, she ain't gonna make it. Or, yes. But do you know what we were basing it off of? Not their actual nursing skills. It was their personality that we were like, yes or no. But I remember being still pretty green. Got to remember, I'm coming from one place and really had to teach me anything into another one where things are completely different. One place, nurses weren't even doing IV push with the medications. Everything was going into like a 50cc bag of saline. I'm telling you everything. So then by the time I come over here to this organization, everything is being pushed. We're mixing our own meds. We're playing pharmacists. We're doing we doing it all. Do you hear me? I remember a nurse making a binder of all the drips. And at that time in this organization, every cardiac drip was mixed, believe it or not, with D5, with dextrose, not normal saline. And I remember this binder and it would have all the drips in it because we had to mix them ourselves. Like we had to mix, we played pharmacists now that I think about it. We really did. We were calculating, calculating them drips, everything, like doing it all. We didn't have those pumps that were smart. You had to know, or you could really hurt
You had to do
somebody.
like, right? Did you have to like calculate drip rates and all that
Yes,
stuff?
we did. Yes. So I don't even know, do they even do that anymore in school? I don't know.
Think so. I don't
We
think they
had
do.
to do all the things. And then you spoke about charting on paper. Let me tell you guys, that makes my heart happy. I love the paper charting because you could tell a story. And the person who would be taking over for you, so night shift will come in when if you day shift, night shift, they could read the story and know what happened. Like, what happened with this patient? Did they come from home? Did EMS bring them in? And what was the situation that occurred? And to me, that eliminated, to me, a lot of the issues that occur in electronic medical records that occur with us actually typing and putting in all the things. There's a lot of mistyping, at least with writing, people could put the line and put your little initials if you made an error and put, you know what I mean? All the things that I know we got to move with times, but my goodness, if they think back on it, either they weren't looking into this stuff as much or it just appeared to be less issues than there are now. And maybe because everybody could see the story. And as that ER nurse, never do we want you to sit there and give us a book because we're never going to remember a bit of not a bit of it, okay? What's left and what needs to be done. Like that's what we need to do. And that's why I knew I was never gonna be an ICU nurse. I didn't want to wash your hair or do your I wanted to focus. I want what are you here for? What are you here for today? And that I mean, I quickly grasped that behavior because at the time nobody was giving any survey scores, as to how they were being treated. I mean, we were the nurses grabbing our breakfast, honey, before we saw you and sitting in an area with with our feet popped up on the desk, eating our eggs, looking at somebody as they call a nurse. But when it came down to it, you were gonna get some phenomenal care. It was when nurses could really be nurses. I mean, we would put you on your head and put that IV in your EJ, honey, like there was no right in the hallway. Like it was magical. I am blessed to have been able to learn what I learned at the time and what I learned it because that is one of the changes that I do see in today's nursing that they are spoon fed. We were not spoon fed at all. It was shit or get off the pot, people. It really was. You can go sit and tell how your feelings was hurt, but we'd be like, suck it up, buttercup. Like there was none of that cuddling or any of the things that we see now. And I do find that that is not good in healthcare. I don't know why we're doing all the things. If you want patients to survive, we got to stop patting everybody and being all like, we can't say this or this, and everybody's feelings hurt. You know what? My feelings would be hurt, but I'd go home and I'd suck it up and I'd come back the next day and I would show you I got this. And that is really where nursing has changed. But that's really the baseline, for me. It was amazing. It was fun.
Yeah, it's kind of it's just it's like hard to kind of pinpoint when healthcare changed. Was it with the, kind of addition of the electronic medical records? Was it when, Medicare and Medicaid really started basing reimbursements on patient surveys? People say the death of like the vital signs or when pain became one of those, vital signs. So it's hard to pinpoint when nursing
It
changed
is.
is no doubt that it has, because I think there's definitely improvements, but there's definitely areas like you kind of said that nurses treated patients medically and gave the very great care, but they got to be nurses. Like the
They
nurses, like
did.
where you gave bed baths, right?
Yep.
Like back on the floor,
Yep.
you gave bed baths and you made sure patients were emulated and you made sure
And
patients,
you change
had
their
their
sheets.
pillows. Right.
You
They
change their
miter,
beds every
ever having to
day.
miter the sheets.
Yeah.
They don't
And
do
then
that
they
anymore.
would use a bucket. I was so appalled
Yeah.
a couple years ago to find out nobody uses the bucket and they just use these wipes. I was like, what is that? Like,
Yeah,
yeah,
it's just strange and, like, it just yeah, like, a lot of things have definitely, like, shifted and changed, and obviously the world has shifted and changed, so it's not surprising, but
right.
it's just it is crazy when you've been in this role for a while and it how you've noticed that that shift happened, and it's like, where? Like, where
Where?
along the lines did it happen? Because it just kind of slowly, I feel like,
It
has
just slid in there.
evolved.
Like, when did
Yeah.
we go to having to wear one color uniform?
Yeah.
Like, I remember wearing what we could wear a t-shirt and scrubs, honey. Nobody cared as long as we was taking care of those patients. But when did it come to a point where all nursing in an organization need to wear one color. And why? Because did that change? Was that something in a survey that was put out there? Did patients say we need this? Because they don't know still who's a nurse and who's not. And patients are gonna ask, it doesn't matter if it's environmental services, a lab tech, ancillary staff, anybody when they need help to please help me. So I'm not sure where all of that even like changed. I can't pinpoint the time and the why. But if
Yeah.
I had to think about all the changes that have been made in my career, I would definitely say healthcare became more business, and it's what they felt they needed to do to continue receiving and in whatever way. I'm not necessarily saying they had to be receiving prior. I don't know if what it was, but it is something, and it could be regulatory. It could be the Medicaid, Medicare. Maybe they put their foot down because they've been there, but maybe they put their foot down and say, "You want to get paid? This is what we expect out of you. This is what we want to see to continue to get." I don't know that business aspect of it. I wish I understood so that maybe I could try and process all the drastic changes because people make changes, but they never tell why. It's just, this is what it is. And it's like, you want a job? This is what you're going to do.
Well, and the other thing is I have a bad memory in general. I have a weird memory, I'll just say that way, because sometimes I remember things really randomly,
You
but,
just
like,
have a lot in your mind.
I
That's
don't recall there being, obviously, like, HCAHPS and EDCAPS and, like, patient
neither.
experience, right? Like, that's a new thing, but, like, also you're kinda talking about that, and I was like, did we have these other kind of patient safety goals? So, like, how there's the
That's a
national
great
patient
question.
safety goals and, like,
Yes.
it kind of focuses on, like, safe medication administration
Yes.
and all of these wonderful things that we should absolutely be focusing on, but,
So
like,
what were
when
we
did it
doing
start?
before?
Yeah,
When
like,
did
when
it
did that
start?
goals start? Because then, like, the national patient safety goals that are out there and Joint Commission does, they are tied to, like, Medicare and Medicaid
Yes.
reimbursement when it comes to, like, healthcare acquired infections and, caries and CLABSIs and all of these things. So, like, there is gotta be some kind of correlation. I just
It's
don't
got to be.
know within the timeline what it is, but there obviously is a correlation between all of this stuff. And I honestly can't remember, like, kind of talking or really focusing on it and probably until the last 10 years or so.
When
And
did they start studying and doing evidence base? Pneumonia's been out all my life. But at what point did they say some studies need to have been done and this is what has to be done? And don't get me wrong, I'm not saying these things not being in place have not changed things for the better. I'm certain they have, but what was occurring before? Were people dying or
yeah, it's kind of, it would be interesting to kind of really dive deeper into this because I think it's an interesting
it
conversation.
is.
Like, I
It
mean,
is.
obviously, as things grow and evolve, like you are looking at hopefully data and trying to make changes for the better. So, like, how were outcomes measured? Were outcomes measured? How
What were
were
the
outcomes
metrics?
measured
Absolutely.
before? And you think these policies, procedures, all of these things were put in place because maybe we weren't doing the best at it, and can caries,
Right.
collapses, and all of these things that we focus on be prevented? Well, yes, to an extent, right?
Right.
Obviously want to be doing the right things and keeping our patients safe. That should always be the forefront of us. But the emphasis that it's being put on and the price, I think it's almost in a way taking, and this is my personal opinion, there is some of it that's taking away from the care of the
It
patient.
is. It has. Yeah.
So it would be interesting to do a deeper dive. I don't have the bandwidth to do that deeper dive, but it would be interesting to do it to see why these things were put into place and what the data or evidence back then showed that made these changes go into place.
Or
That would
were
be an
they or
interesting thing.
was there any data or evidence
Yeah, that's true.
before?
Yeah. Yeah. Were they even
And
keeping
then
statistics,
and
right? Like,
then it was put out there, we need data and evidence
right.
if you wanna be paid
Yeah.
to make sure that these patients are being properly cared for in this way. Like,
Yeah.
but at what point
Yeah.
that be you're right. That would be so interesting to
It
dive deep
would be.
into and find out. Like,
Well, because the other
because
thing I was thinking was just we look at, and this has obviously changed over time because you look at the average life expectancy, right? And it is
right,
definitely grown over the decades and, centuries from, people were only living till their 20s and 30s, and now people are
right,
living till their 90s and 100. So
right.
we obviously have
Oh,
longer
definitely.
lifespans, right? Because we've had
Absolutely.
advances in medicine, etc. But as the population continues to age, there's also that longer period of time we're having to take care of people with these high morbidities and
Absolutely.
mortalities. So, like, that puts a pressure on a healthcare system, on the whole healthcare system. We have patients that are so much sicker that we now have medical advancements to treat them. Like, you're a perfect case. And you know this too. 20 years ago, if somebody got diagnosed with pancreatic cancer, they don't have the technology. They didn't have that technology back then that
No,
they do today.
no,
Like, that really was
no.
a death sentence back then.
I mean, it was a death sentence as long as I
Yeah.
can remember.
So, like,
And I'm
it is.
serious. It was straight up a death sentence.
Mhm.
Like, I am still baffled about it because, yes, technology has come a long way and there's so much more research and things like that that are out there. There's still pretty significant amount of people that have, passed on with it. But I would love to dig into that to know what was the change that came about where now a person could live with this, like myself. Like, I want to know, you know? It's so interesting. The downfall of all of this to me, Brittany, though, is that are we so caught up on making sure all those metrics, all these things are in place that the nurses, healthcare people in general aren't really learning, or I don't know, or being given
Yeah.
had to know to do? I don't know. Like,
So think there's a part of it that's, with the change in society, right? It's almost like nursing was, they said an art before, right? It was an art. And you
it
had
was yeah.
kind of care, right? And I'm not
Right?
saying this like now, but
No,
there's
right.
a lost element of like that human connection that
Yes.
used to be more of an emphasis. I do feel like it used to be more of an emphasis on that human connection, and it used to be more of like
Yes.
art. And now it's becoming more of a science as I feel like nursing has shifted a little bit more into that science background. We've shifted more into that research and evidence and numbers and
Yes.
data.
Yes, you're
And
absolutely right.
I think a part of that has come at the expense of that human touch and interaction. And
Yes.
once again, personal opinion, but I do feel like that I love data and research, like I really do love having numbers and statistics. But with that, I do feel like has come a shift that we're kind of focused more on that sometimes, and especially at a senior leadership level or a bigger hospital system level, than the unmeasurable human touch and interactions that it has kind of been lost. And I mean, I know overall as a society, we're a lot less human connected and a lot more social media and computer connected and all of these things. So that's, I think, just a shift with society. But I think that plays a part in it too. Like kind of you're
It
talking about.
does.
It's
It
just,
does.
and then I think that trickles into kind of what you're talking about with people learning, because as society, we've gone ahead, there's been more of an emphasis on virtual, like, right? We do a lot more virtual learning and more of a focus on kind of like teaching yourself type of situations, right? Like you
No, you're
go,
right.
read that or do that, and you don't maybe have that lecture piece of it, or even clinicals are a little are different than I remember back in the day, and that's me being a clinical instructor, and it's
Less hands-on.
yeah, it's just kind of like I don't know, because it's like a mind shift, and I really try to like say this to my students, like, you're gonna be out there like taking care of these people, so you need to use this time to the best of your ability. And it's like some people take that and some people don't, and it's like hard to get them to I think sometimes like buy into it. But yeah,
But I guess one of the questions would be also, what made you get into nursing? Like, I
right.
would wanna ask that because I remember there were people that used to be like, "Well, I really got into it because of the money," and I'm like, "Wrong." Like, that is definitely something that it's not gonna make you love it if that is your reason for these are people's lives. And, you know, what makes a person do it? I've heard people say, "I do it because, my mom did it," or "This family member was a nurse as well." Okay, but I didn't have the desire and got into it and absolutely loved it. There are people who say they've always wanted to do it and they get into it and I'm like, "Did you really want to do this in life?" Because, you see how they treat their patients, or whatever. But I don't know. I really do miss those early years. I do.
Yeah,
That because you nursed in those early years. And
and it's
and as
kind
someone
of
that's an educator now, I find it difficult to educate
yeah,
nursing staff now. I d
and it's there's so many, like, there's way more questions than answers, obviously, with all of this stuff. But, one of the things I actually, I've been doing little bit more kind of self-reflection as well as like a little bit more research, because it has really interested in me in the topics of like burnout, compassion fatigue, and all of that
yes,
stuff. And, I actually just made a post about moral injury, which is, I think, something newer. It's definitely a newer term that's kind of out there. And I think it's something that with advances in healthcare, there's also that internal struggle. So, for instance, right, if we got into it right with that, we want to help people, we want to care, but then you get into a system where it's very based on kind of protecting your license and
your
yourself.
license,
Even
right.
and I was talking to actually a team member recently, like, about moral injury and how, we're keeping people alive now that maybe we wouldn't have done 20 years ago. And we're
That's true.
prolonging life at the
Yes,
expense of kind of just keeping them around rather than looking at their quality of life. And that
exactly.
can cause a really big moral injury to people, that they're having to do things that go against their true belief
That's
and wanting
true.
to help people, because that's not really helping that person.
Right.
That's just prolonging suffering in a way. And so that
Yes,
causes a lot of like moral kind of injuries
it does.
is, which takes a toll on people
It
when you
does.
are put in situations where you're having to compromise your true core values. And that makes it really difficult in a healthcare system that has shifted, I feel like, I shifted away from really looking at that kind of whole quality of life, the holistic, right? We did the holistic care of people and looking at all aspects and really just looking at how can we move patients along in our system, and how can we, get patients back to just kind of their baseline. And it just there's definitely been
It
that
is.
shift as well, and
Yeah.
that definitely causes more distress on healthcare workers,
No, it
and I think it
does.
burns us out. right? And,
No,
that
it
it doesn't
does,
go
and
through.
actually, you brought up a good point because my question to everyone even out there and to you, like, or ones who've done it years ago and away from the bedside, how many of you would be that bedside nurse today? I think about that question because I don't think I would. I really don't think that I could be that bedside nurse today, which then makes me feel sad
Yeah.
for
Like,
the
because you can't
nursing
be the
home.
kind of nurse you want to be.
No,
And that's the other part of this, right? There are, I feel like, systems in place almost that prevent people
prevent
from
you from
being
being
the type
able
of nurse you
to.
wanna be, which
Absolutely.
sucks. Like,
It does, and then when I think about in that case, that is where nursing has changed, and it's not always on the nurses that are put out there. They're very limited as opposed to when I was doing it, and like we had to really learn it. Like you didn't learn it for the moment. Like we had to know it. And now I feel like they're bombarded with so many constant, this needs to happen, this needs to happen. You need to do this, you need to chart this, you need to make sure you're telling this person this, that. It is so overwhelming. I don't think the human brain can handle all of it. And I just think that it's too much.
I literally was gonna say that exact same thing. You literally said it so perfectly and stole the words out
It's
of
too
my
much.
mouth, because I
It is.
think that's another piece, right? There is so much advances now, and there's so many things that nurses are needing. Like, there's, it's like, what are your top priorities? Well, you have 10 top priorities. Like,
Right.
that you can't have 10 top priorities.
Can't
That's not
have,
how it
right.
works. So, like,
Right.
you're being set up to fail
Right.
automatically because the system as a whole, all of healthcare, and especially our, in the United States, there is competing priorities. And so when you have competing priorities, nothing can kind of
One.
fill up. So, like,
Right.
you're being forced to tell everybody all these things, but it's like cognitive overload, and people
It
can't
is.
kind of
They can't
retain that
they
information because you're
can't retain it.
constantly having to, like, turn it over into something different. It's like you
And
can't.
and and how much can you continue to give them in badge buddies or making binders or, because our human brain just, can't handle all the constant changes, and then everybody wants to know, well, why can't these people remember? Well, we bombarded them with constant changes. Like I know even as an educator the constant changes that I'm like, I'm going to have to decipher between what I think needs to be put out right now because it's just so much. And they
It's
can't, it's no way.
it is, it's so true. You're like, "I need you to learn everything about sepsis, and then I need you to learn everything about cardiac CHF, and then everything about trauma, and everything about this thing and this thing." It's like, who can? And then, okay, here's this process. Nope, 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 nope. We found this workflow. And that's fine because things do change. We understand things change. Things don't work. You try it, it doesn't work. But, like, when there's constant change, that makes it really difficult for somebody to be able to keep up.
It's
Truly.
true.
It's
It's true.
so hard. Like, yeah, like you're kinda talking about, like, looking back now at where healthcare is, would I have still chosen to go into nursing? And I honestly don't know. Like, I
I
really
don't
don't
know
know
either.
because,
I don't.
I've been away from the bedside now for a little bit. I still, occasionally pick up here and there, and I still really love it. I still really do love interacting with patients and taking care of patients, but, like, to do that every day, that mental load is just, like, extreme, and, like, you're constantly, like, I feel like just being set up to fail, like, so
You are.
it's
You
so
are.
hard, like, it's
You
really
are.
hard, and, like,
It's
I don't,
hard.
yeah. So,
And it's something that I can't even begin to say how to be fixed. I don't
yeah,
even,
it's
I don't know.
I don't know either. Like, it's crazy to, like, look back, because like honestly, nursing was fun. Like,
It was so much fun.
you interact, like you had these awesome like teams, and right, you had this like really close knit team, and like you went and like did things together, and not saying that
They
people
were your
obviously
family, your
don't,
work
but like you
family.
would joke and like have fun at work, and like it wasn't anything bad. Now like you make a joke at the nurse's station,
Everybody's
but over
offended
hears
and
it,
that
and it's like it's just like nursing used to be a lot funner, like more
it
fun.
was fun and it was autonomous. It's none of that now. It was like it was such a rewarding feeling to be like, I'm a nurse. Like I'm an emergency room nurse. Like I felt like a hero. Like seriously, like making a difference. And then as healthcare has changed, it is burning out nursing staff. I see it. Like I see it. I recently onboarded someone, not even in emergency room nursing, who literally was on orientation and resigned before the shifts could be done. And that's where we are today because it's so overwhelming and it's just not fun anymore and it's burning people out. And people just don't have it in them to to do that, to deal with that and all the constant changes. And why are you worried about, I mean, yeah, it's cold, I got on a jacket. Why are you so worried about whether if it's fleece or not? Or why do we worry about such small things that I'm just happy that people are making it to work and that they're caring for patients, but then we worry about certain things that I just think that they really should not worry with. Worry less about those things. And maybe people will not get so stressed out when you're coming down on them about other things. Like, I feel like we need to start picking our battles, if that
Yeah.
makes sense. You know, and I do know that that depends on the department and the leader that they have. If they, you know, but just to say to the leaders out there who are, I understand being black and white, following rules, but sometimes we have to pick those battles too. Like those are things that are pushing nurses away. They're not like how I was. This loyal person, feelings might get hurt, go home, come back the next day, start all over again. They're like deuces. I ain't coming back. Like, and those are the things we need to figure out the why. Why, but I don't know if those things will ever change. Will they continue to just get worse? Where will healthcare be years from now? And
So
it's
many
scary.
questions. We got so many questions and
We do.
so little
With no
answers.
and no answers. So if you have some answers, please share them with us because
Yeah.
maybe there's things that we just don't know. It's so interesting, Brittany, that you were saying how, you never really work the bedside, but occasionally you definitely do. I was just thinking about that. Like wanting to occasionally just, I don't want it as a full-time thing, but jumping back in because I do love taking care of patients and seeing them turn around from being very sick to where we have pretty much nursed them back to where they're on the road of recovery. That is what was rewarding to me as an emergency room nurse. Like nothing to me was any better. I'm sure maybe labor and delivery nurses feel that way when they deliver the babies. But those are the things that I do miss. And then I just was saying maybe you need to just not as a shift, but like start jumping in throughout, maybe even a day or whatever, and trying to get myself back in there because right about now it's kind of scary when you've not done it for some years. They say it's like riding a bike,
It is.
but and I don't want to not feel that comfort that, well, it's never should you feel that comfortable. You should always be willing to continue to learn because let me tell you something. Us seasoned nurses need to know that things have changed and they're not the way that we have known them to be. And as an educator, I realized that because oftentimes I have to look up in our resources to make sure that I am giving the correct information to our clinical staff just because things have changed. Not always because I didn't know it. Some things I may not know. I'm going to tell you if I don't, but just because things have changed. I remember being told that they didn't aspirate anymore with IM shots and being shocked. I couldn't believe it because me as a nurse, that's what I do. That's how I learned it. They're like, oh, they don't do that anymore, Felicia. I'm like, wow. So,
Yeah.
you know,
Well, I mean, medicine is constantly
it's
changing, and
constantly changing. And I
there's
miss,
definitely good things about that, right? Like
oh
I
my
said, like
God, definitely.
we are making advances that are really changing patients' outcomes, really changing
Amazing equipment.
mobility, mortality, and really improving patients' lives and really letting them
Yes.
fully like have recovery with ADL. So like there's definitely a great shift
Oh
in
my God, there is.
medicine. Obviously, like, we talked about before, like Felicia's still here with us because of shifts in
Real here,
medicine.
bro.
So like it is not always a bad thing. It's just
No,
how do you kind of have more of a balance, and then
I
we've
don't
sat here
know.
talked about it for an hour now, and we're still like, "Oh, we don't know." So, is there anything for our stethoscope moments that we wanna talk about before we kinda wrap up this very intense but really great conversation episode? You
Just
got
that,
anything?
my dropping that stethoscope moment is just the excitement of I see new growth coming along. For me, I see some changes. I am very excited about that and the opportunities that could come along with it. And just continuing to try to stay in good health to keep you up on things. I do go to the doctor on Thursday, and I am going to try and have a conversation to discuss what those next steps. I think I mentioned that in our last episode, but just want to let you know that's coming soon. And other than that, just trying to stay positive and not fall in my bubble too much. So I'm doing pretty good these past few weeks. I'm feeling really good. So that's just a moment that I wanted to be able to share with everybody. How about you, Brittany?
I'm trying to think since our last episode. So it's really funny. We were talking about like shows last week, right? And I still
Yeah.
have because I haven't watched it yet.
Okay.
So we'll have to talk about it soon. The Shack, right? It's I still got it on my to-do list, but
I need you to watch it. And when you see me Thursday, there needs to be a discussion.
I know I'm gonna have to put on the agenda for tomorrow. But I think there was like a moment maybe last week where I was just like, I can't shut my brain off. I can't, like I constantly do it. And my boyfriend was like, you need to stop like worrying about kind of because I'm trying to like kind of grow my social media and things like that. He's like, you just need to just chill. Like he's like, you never really because I said this, I'll never really stop and like watch shows with him or do that because I'm just constantly like I gotta figure out what to post next, or I've gotta like figure out how to market my class, or I've got to, like all these other things. And he's like, you just need to like put your phone down. Just like, it's okay for it to just be away and just literally like completely check out. And I was like, okay. So
Right.
I'm really going to try to just like try to plan my like social media stuff a little bit better. So I'm not constantly being kind of consumed with it.
Right.
Social media is wonderful and it's really opened up a lot of new doors for me and kind of my career growth and different aspects outside of traditional nursing, but I don't want it to consume me. So I'm trying to find
No,
more that balance. So
no.
that's kind of where I'm at right now is
I
trying
love that for you. I love it. And thank you.
to
Thank you, Tony. I love that. Thank you for telling her because
I
life
know.
is too short. So we need her to like just put things in the bucket where they need to be and then shut things
Yes.
off
Yeah, because
so
if
that
not,
you
I
can
will
handle it.
constantly be going and I'm just like, okay, what social media trends are out there now? What do I need to jump on? What do I need to post it? Like, so like thinking at it really in like that business kind of mindset, but it's the same thing. If it's gonna be another consumption thing, like it's just not worth it. And he's like, it's not worth your mental health. So I'm like, I'm
Mhm.
gonna try to have more of a balance for sure. So
I
that's
like
my
it. I love it. Love, love,
dropping my
love.
stethoscope moment is, as much as he can be a pain in my butt, my boyfriend
He's
is
right.
he's great. He's a great balance for me.
He's
So
right. He is a great balance, and that's exactly what you
yes.
needed to hear, my friend.
Yeah.
Just like you tell me when I need to like,
Yeah. Sometimes we just
friend.
need that like shock of truth to like get us to be like, okay, that stung a little bit, but thank you because I really needed to hear that. So
Yes. So, guys, it has been another wonderful episode talking with you.
yes.
Please
So
love us
well,
and
I just
send us.
wanted to say, just to kind of wrap up this
Yeah,
episode, there's a lot of things that we've talked about. Like we can't control staffing or patient volumes or acuities or policies, and we can't control a lot of things. But what we can control is how we show up
there
to
you
work
go.
every day. Like we've talked
There
about
you go.
positive attitudes all the time and being kind to yourself, giving yourself that grace. We've talked about that last week, and giving your coworkers grace, being kind
Absolutely.
to patients and to coworkers, and just remembering that a lot of things have shifted, but every shift that we go to work is still an opportunity to make people feel seen. Like we talked
That's
about kind
right.
of losing the art of nursing. Well, we can consciously work to kind of bring that back. And it's tough, but we can do it. Like we
We
can.
can do it.
Just it's hard. We have a lot of systems in place around us, but those are things we can't control. So we got to work on what we can control. And that includes myself, Felicia, everybody, right? We can
Absolutely.
all have room for improvement. So once again, thank you for listening
Yes.
to our please drop a comment if this resonated with you or like what your ears doing differently that's kind of shifting things or like how things are working at your place because all ERs work a little differently.
Absolutely.
So
Give the input, share.
talk to us. Talk to
Talk
us.
to. Let us know. Guide us. Help guide us, guys.
Yes.
Yes.
Well, thank
We
you
love you
again.
guys. Thank you. And make sure you have a lovely evening.
Don't forget, like, subscribe,
Yes.
share. We love y'all. All
Love
right. Bye,
you.
guys.